Good evening, doctors. My name is Rahul Desai, and on behalf of FDC and MedTalks, in our journey of 52 weeks of diabetes essentials with Dr. Sanjay Kalra, I hereby welcome you all to today's live module brought to you by ENERZA Zero and in memory of Dr. K.K. Agarwal, sir. Dear viewers, proper glycemic control in diabetics is like walking on a thin rope, and one mistake, and patient's glycemic control can go haywire. So before I hand over this platform to Dr. Kalra sir to take us through today's topic, that is mistakes in diabetes, let me have the opportunity of announcing the winners of last episode's quiz. And the winners are from Delhi, we have Dr. Bimla Kapoor, Dr. Sumita Sharma, Dr. Umesh Kumar Malhotra, Dr. Prachi Garg, Dr. VK Arora, Dr. Rajiv Handa, Dr. Vinod Ladia, Dr. Manu Sharma. Then from Karnataka, we have Dr. Anupama Swamy, Dr. Ravi Bhatt, Dr. Ajit Hegde. From Odisha, Dr. Gangadhar Rath. From Punjab, Dr. Surinder Gupta. From Rajasthan, Dr. M.R. Chipa. From West Bengal, we have Dr. Shantanu Kumar Bhattacharya, Dr. Ashutosh Das. From Maharashtra, we have Dr. Damodar Jeswani, Dr. D.G. Parmar, Dr. Abhijit Sangvi, Dr. Praveen Hundiwale, Dr. Kaval Saluja, Dr. Rajeswari Sunku, Dr. Hutoshi Zaroliwala, Dr. Neeta Kochar, Dr. Anand Purandre, Dr. Pradeep Gavit, Dr. Somnath Suryavanshi, Dr. Saroj Narang, Dr. Anupam and Dr. Suman Agarwal, Dr. Sushant Kamble, Dr. Sanjeev Desai, Dr. Kulbhushan Tandon, and Dr. Dharmika Tandon. From Uttar Pradesh, we have Dr. Asma Saeed, Dr. Irfanullah, Dr. Sanjay Mehrotra, Dr. Arun Kumar Garg, Dr. Pallavi Rai, Dr. Devrat Rai, Dr. Sushil Kumar Shivnani, Dr. Ashwini Kumar, and Dr. Suresh Kushwa. So congratulations to all those winners of last episode. And with this, I hand over the platform to Dr. Kalra sir to take us to today's topic. Over to you, sir.
Thank you, Dr. Thank you, Rahul, and warm greetings to everybody. It's as usual, it's very pleasant interaction being with all of you. We all manage diabetes, but sometimes we make mistakes. Many times the mistakes that we make are forced errors. At other times they are unforced errors. We make them, without any reason. So many times we have a reason. I didn't have enough time in the OPD. Or I had time, but I was too tired. I was exhausted after a full day's OPD. These are forced errors. But unforced are that unknowingly we make mistakes. So today, we'll talk about mistakes in type 2 diabetes and how to minimize them. Now, I doubt if there would be any human being on earth who has not made a mistake. If that is correct, then there would be no doctor in the world who has not made a mistake. And I would be the first to admit I have done that. So once we know what common mistakes we make, we can then make an effort to minimize these errors in practice. We'll talk today about errors in the screening and diagnosis of diabetes. We'll then talk about errors in therapy and monitoring, mistakes that we make in complication screening and care, and then we'll conclude with a brief summary of communication and community approach. Now let's look at screening first. In the United States, the US Preventive Task Force, the United States Preventive Task Force has recently recommended screening for diabetes and prediabetes in every adult above the age of 35 every 3 years. But they also say that in ethnic groups like Asians, we should screen early at an earlier age, and we should screen more frequently at 1 year interval. If we extrapolate this, then every adult Indian should be screened for diabetes at least once a year. This is important because we have a high prevalence of diabetes, and we also have a very fast progression of disease from normoglycemia to prediabetes to diabetes. So universal screening should be recommended in every adult above age of 30 in India. But you can also do opportunistic screening, and we'll talk about that. What that means is that when an opportunity presents, when a patient comes to your clinic, use that opportunity. We'll talk about that later. But some errors that we make. We tend to use the word sugar in normal language. As part of English or Hindi, that is fine, sugar or shakkar. But the correct scientific word is glucose. There is a lot of difference between glucose and fructose and sucrose. So please make it a habit to use the word glucose, plasma glucose. And if your lab continues to write blood sugar, please get it corrected. Let's take a vow that tomorrow we will go back to our clinics, and if our lab has got a printed value or sugar written, don't throw away those pads, but at least cut it and write glucose. Another mistake that we make is postprandial versus post-load. The diagnosis of diabetes can be made by either a fasting glucose or a post-load or post-challenge glucose or a random glucose or HbA1c. Nowhere is the word postprandial used in the diagnosis of diabetes. Postprandial is used for monitoring. So when you are screening, either we'll do a fasting glucose or we will do a post-load glucose, and the load is 75 grams of anhydrous glucose, which is equal to 82.5 gram of hydrated glucose. And the glucon D that you get in the market is not anhydrous, it is hydrated. So if you want to measure glucon D, then it has to be 82.5 grams if you want to do a good GTT. In pregnancy also, GTT is done with 75 grams, but the normal values are different. So we should be aware of this difference. Any glucose value more than 140 in pregnancy will be diagnosed or defined as gestational diabetes. Let's talk about opportunistic screening. If you want to focus on high-risk patients in your clinic, in your community, focus on the following. Patients with symptoms suggestive of diabetes or complications, like neuropathy. Patients with metabolic comorbidities that you know exist along with diabetes. D for diabetes. D for darkening of skin, that is acanthosis nigricans. H for hypertension. H for heart disease. O for obesity. O for obstructive sleep apnea. L for lipids, dyslipidemia. L for fatty liver. And also L for laziness. Focus on patients who have got target organ damage. Atherosclerotic cardiovascular disease, which can affect the cerebrovascular bed. So that means patient might have stroke or transient ischemic attack. It can affect the coronary bed. Patient might have unstable angina or myocardial infarction. It can affect the peripheral arterial bed. Patient might have ischemic diabetic foot. It might affect the pudendal bed. Patient may have erectile dysfunction. Also, heart failure is another target organ damage. These are macrovascular. If it affects the microvasculature, retinopathy, neuropathy, nephropathy, these are also target organ damages. And then again, we must screen for diabetes in anybody who has got retinal disease, kidney disease, or nerve disease. When we do this discussion about diabetes, we are always talking about chronic diseases. But in India, in our clinics, in your clinic, in my clinic, acute comorbidity is more common. So many acute comorbid conditions are syndemic with diabetes. There is a diabetes epidemic, but it overlaps the epidemic of depression. It overlaps the epidemic of tuberculosis, of hepatitis B, of sexually transmitted diseases, genitourinary infections. So in all such patients, tuberculosis, hepatitis, genitourinary infections, sexually transmitted disease, depression, HIV, in all these, again, we must screen for diabetes. If you have a patient who has been taking drugs of unknown origin, maybe Ayurvedic, maybe otherwise, might be anything, for a short term or long term, then again, look for dysglycemia, because many drugs like corticosteroids and immunosuppressants can actually cause dysglycemia. So first we focused on present history, symptoms suggestive of diabetes. Then we talked of metabolic history, comorbidities and target organ damage. Acute history, acute comorbidity. Then we went on to drug use. Now let's talk about past history and family history. If patient has had a history of GDM in the past or a history suggestive of GDM, IUGR, heavyweight baby, hydramnios, pregnancy loss, we must screen for diabetes. And COVID also might emerge as a pre-diabetic condition now, because after COVID, we see so many reports of dysglycemia, type 1 diabetes, type 2 diabetes. So maybe post-COVID patients also should continue to be screened annually, if not more frequently. A family history of diabetes is also a high risk for development of diabetes. So if anybody in the family has diabetes, we must screen such patients. So we have spoken so far about errors in screening, but now we have identified the types of patients in our OPD whom we'll go out and say, and we'll say it in a positive manner. Young man, we must get your glucose done every few months, at least every year. And the reason is that if we catch it early, if we catch it in the phase of pre-diabetes, we will be able to prevent you from reaching diabetes. We will be able to prevent you from getting complications of diabetes. So this kind of a message should go to everybody in our community. Once we have screened, we should know the diagnosis. We should know the cutoffs for pre-diabetes and diabetes. We all know that. For diagnosis, ideally venous blood should be used, but for monitoring, capillary blood will suffice. Many patients will come and argue, doctor, your machine always gives a higher glucose. When I go to the lab, then my glucose comes down. So we explain, and don't go on the defensive, you go on the offensive. Sir, in the blood, in the body, there are arteries and there are veins. Your heart pumps good quality blood, which contains a lot of oxygen, lot of nutrients, lot of sugar. And this goes in the arteries. From the arteries, it reaches the capillaries, and we take your blood from there. We are checking good quality blood, and that gives you the exact number of glucose. All this glucose, all the nutrients and oxygen are used up in the tissue, and from there the bad blood goes back in the veins. You can see the color when we prick your skin, your finger to get the capillary blood, it is bright red. When we take a venous sample, it is dark red. Number one, we are taking more ml, we are taking 2 ml of blood. Number two, it is bad quality blood. There is no oxygen, there is no glucose. And so, of course, the glucose level is going to be less. If you want an accurate number, that is capillary. Now, this is a way of motivating your patient and counseling your patient. Of course, we should ourselves be aware of the difference. And you can very confidently say that even if the President of America were to get his glucose monitored today, he would get it done using capillary blood. Also remember that symptoms and lab numbers are equally important. If you have symptoms suggestive of diabetes, a single lab abnormality, fasting, post-load HbA1c will suffice for diagnosis. But if there are no symptoms, you need at least 2 abnormal lab tests to diagnose diabetes or prediabetes. You can also talk to your patient about lab versus glucometer. In the glucometer, we give you real-time glucose. But if we take a sample and we preserve it, and then the glucose is done after maybe 5 or 6 or 7 hours in the lab, because the lab will not do one test at a time. It will wait for all the tests to come. Then with every hour, there is a 7% reduction in glucose value because the glucose gets used up by the red blood cells. And so let us say I took a sample at 6 a.m., but my lab checked it at 12 noon. Of course, the glucose level will come down markedly. HbA1c is also important for diagnosis and monitoring. Many of us do not use it for diagnosis, but it is a good number which you can use to motivate your patients with. So we are talking today about mistakes in diabetes care. We have spoken about screening and monitoring. Let's move on to management. The cornerstone of a good physician's practice, of a successful physician's practice, is not how well he can prescribe drug therapy. It is how well she can motivate her community. Let me repeat, not the individual patient, but the individual patient, the family, and the community to follow non-drug therapy. This is the key to becoming a successful chronic care physician. So 5 S's to remember: sensible sustenance or diet, structured physical activity, stress management, sleep hygiene, and preventing or managing substance abuse. What is the way to motivate your community? Few take homes. First of all, follow these things yourself. Number 2, tell your patients how you are following them, what challenges you are facing. Tell them that you understand the challenge that they may be facing, but still we have to do our best. Third, inform that diabetes is not just a disease of the individual. It is a disease of the family and of society. So ask everybody to support your patient in offering good diet, support for diet, in offering good exercise and sports and physical activity, in supporting the patient to do that, and in helping manage stress and getting good quality sleep. If we can get our hands around this, then we are through. We will have a successful practice, a flourishing practice, and also a very rewarding practice, in the sense that you will feel happy that you are able to help your patients. There are issues, however. Many times it is easier said than done. I myself get irritated and frustrated in the OPD sometimes. My biggest pain point is that I keep on telling people not to eat, not to take ghee. And people will find the funniest of excuses. So I'll tell them, don't take ghee. And they will say, but sir, you didn't say butter. I'll say, don't take butter, don't take makhan. And then they will say, but sir, you didn't say the homemade makhan. In Haryanvi, that is called tindi. So now I say ghee makhan malai tindi. But then they will say, sir, you didn't say cooking oil. So I didn't take any ghee, but I put 2 dollops extra of mustard oil. So then I say ghee makhan malai tindi and sarson ka tel. That is what is used most often in Haryana. And then recently one patient came and said, sir, you told us not to use all these. So now I have begun putting olive oil on my chapati. And I had never imagined in my whole life, I mean, in my 7 lives, I would not imagine that a person from Punjab or Haryana would use olive oil to put on the chapati. So, but you have to keep on listening to the patient. Be patient yourself. And when you're speaking with the patient, you try to learn the patient's strengths, limitations. Also look for opportunities to put forward your point, and see the threats to your communication. In management also, this is called a SWOT analysis, SWOT, strength, weakness, opportunity, threat. So you use the same analysis for each patient. So let me share a few methods now of making sure that we are able to get these 5 S's across. First of all, do a SWOT analysis. Play upon your patient's strengths. Help him or her overcome the limitations and weaknesses. Explore opportunities to communicate with the patient, and be guardful, be mindful of threats. Threat might be from the neighboring complementary or alternative therapist. So preempt that. Yes, these people are doing a very good job of managing diabetes, but you see, for the past 5,000 years, they were not able to make a glucometer. Now, if our outcome is measured by a glucometer, then our process should be related to the glucometer. See, that is such a soft way of telling the patient that alternative therapy is not effective. All the tests that you are getting done have been developed by allopathy, not by other schools of medicine. So these are just some ways of preempting threat. Let me share a 2x2 factorial to help us define motivational strategies. All your patients can be divided into 4 groups. Let us see how that is done. Some people are motivated by subjective or emotional cues. So to such a patient, and almost every Indian will come in this category, sir, please allow me to give you this medicine. It will help you bring down glucose. That will help you keep your organs healthy, including your joints. You will feel much better, and now you will be able to knit a sweater for your grandson or your granddaughter. Now the picture is the granddaughter, and you are motivating that elderly lady to take insulin or to take the tablet that you wanted to prescribe. Some people, however, will not be motivated by this. They are very objective, very hard-nosed kind of people. The younger breed is like that. So they will say, sir, your HbA1c is 7.1. Now this risk is unacceptable. Let's bring it down to 6.9. To do so, please allow me to add this tablet. So some people are motivated by objective numbers. You can use HbA1c, microalbuminuria number, total cholesterol or triglyceride number, whatever is high. So you can say something like your triglycerides are 300. Either we add a separate tablet to bring down the triglycerides, or an easier way is, let me give you this glucose lowering drug. It will kill 2 birds with 1 stone. We will be able to achieve good glucose control. Your HbA1c will come down, and your lipid profile will also improve. So this is an objective motivational tool. Now we have divided patients into 2, but I said 4. So all patients are also divided according to their need for achievement or fear of failure. There are many motivational strategies or theories in the world. The simplest one is a binomial or bidirectional theory. And it says that some people are motivated by need for achievement. Most doctors are like that. A child who scores 79% marks in school will be motivated by a need for achievement. So you'll say, why don't you do better? Why don't you do better? So that you can score a distinction. Most patients will come here. So you tell them, let us make this HbA1c better. Let us make your joint health better. Let us make your sexual health better. That is how we motivate them to take insulin. But some people are motivated by fear of failure. Imagine a child who is scoring 34% in school, and you tell that child, why don't you study more beta so that you can get a distinction? The child will laugh at you. He will say, sir, I am worried about failure, and you are trying to motivate me with achievement. So some patients are like that also. In them, you talk about fear of failure. Sir, why don't you take this insulin so that we can prevent your heart from failing? You still have to get your daughters married, so we need to keep your heart healthy. And but then even here, don't be too rude, don't be too judgmental. A nice way of continuing this sentence and completing it would be, now when your son gets married, you have to hug your the Hindi word is samdhan, your daughter-in-law's mother. So we have to keep you handsome, we have to keep you smart, so that you are able to hug her very well. So just a very soft way, a humorous way of bringing need for achievement even here into this fear of failure process. So now 4 groups of patients, some motivated by objective cues, others by subjective, some motivated by need for achievement, actually most of them, and some motivated by fear of failure. This will help us decide our motivational strategy. Once you've got hang of this, the rest is easy. It is a cakewalk. Now, of course, we have to write drugs as well. So the errors we make are, the commonest is in choosing a drug class. We have discussed this in the past few weeks. For some people, you will have a sensitizer. That is like bactericidal or bacteriostatic or glucostatic drug. But for most people, a sensitizer alone will not work. So you have to add either a glucosidal drug, that is sulfonylurea or repaglinide or DPP4 inhibitor. And you also would like to add a nutrient load reducer, which reduces the nutrient load, which also reduces CV risk. These will be SGLT2 inhibitor or GLP-1RA. So make sure that you are giving the right drug class according to your patient's need. Once you've decided your class, I want to give a sulfonylurea and metformin. Then you decide the regimen. Should I give the tablet separately? Should I give fixed dose combination? Should I give once daily? Should I give twice daily? This will also help you decide your preparation. Should I give glyclazide or glimepiride? What is the cost of each? Then we come to the dosage and then dispensing. So to some patient, you might give 0.5 milligram glimepiride plus 500 metformin. To others, you might give 1 milligram plus 850 or 1 milligram plus 500. I would suggest that you stick to minimum trade names and minimum dosage permutations combinations. The errors will come down. Not only our own errors as doctors, but also our pharmacist errors, pharmacist's work, because he has to dispense the drugs. So the more the number of drugs that are being used, the more the chances of dispensing error. Medication counseling is also important. We must focus on this. If you have written insulin or you've written sulfonylurea or SGLT2 inhibitor, you should tell the patient how to use it. And once again, the more the number of drugs we are writing, the more the chances of drug-drug interactions. So a way to minimize these errors is, so see, first we talked about screening and diagnosis. Then we talked of non-pharmacological. In non-pharmacological drug therapy, we have said that you minimize errors by learning communication and motivational skills, by taking the community and family on board. For drug therapy, make sure that your prescription is rational, limit the number of drugs that you use, limit the number of trade names that you use, and you can always rationalize timing of treatment. Like all the medicines take 5 minutes before breakfast or 5 minutes before dinner. If you make it very complicated, one tablet 30 minutes before, one tablet 5 minutes before, one tablet 10 minutes after, anybody would get confused. So for some, of course you have to be very strict, like thyroxine. like proton pump inhibitors. But for the rest, honestly, it will not make too much of a difference. So 5 minutes before is what I use most often in my clinic. Now we've screened, we've diagnosed, we've managed our patient, but we have to monitor as well. And many times we sort of go loose here. This is called mid-sag. So we have to be glucovigilant. Tell the patient also to be vigilant. Keep on checking glucose regularly. Teach the patient about hypoglycemia and hypoglycemia awareness. And also tell the patient that part of my job is to screen for complications so that I can prevent them in you. You have to tell this to the patient. Our aim of giving you treatment is not just to give you a good glucose number. It is also to give you good quality of life and good quantity of life. So therefore, do not forget to screen for blood pressure. Foot examination. Do remember to see the feet every time. Send your patient to a retina specialist at least once a year. And these are all chronic vascular things. But in India, like I said, in our OPDs, it is the acute things which are more common. So one common mistake I see amongst physicians, we do not take a history of infections. So my normal conversation in the OPD would be, do you have any headache, any cough, ear pain, ear discharge, common cold, pain in the neck, any cough, pain abdomen, burning urine, any difficulty in passing stool, any diarrhea, any skin infection, any soft tissue infection. All this comes out as one sentence. It just takes half a minute. And what I see most often in my OPD is genitourinary infections. So especially with people of the opposite gender, you have to be very careful, very diplomatic. So, sir, any infection, any itching, any pruritus, anywhere in the body, sir. Sir, any pruritus anywhere in the urine area. Translate that into Hindi. Bathroom wali jagah pe. This is when you are speaking to people of the opposite gender. कोई ladies वाली दिक्कत तो नहीं है, कोई gents वाली दिक्कत, कोई आदमियों वाली दिक्कत. Any ladies health issue, any men's health issue that we can help you with. And melanoposthitis and pruritus vulvae are so rampant and they are the cause of poor glucose control. So we have to screen for this all the time. Also, another common issue that I face is tuberculosis and then frozen shoulder. If we are able to fix these up, glucose control becomes much easier. Once we have screened for complications, we have to care for them. So some mistakes that we make that I would like to highlight. We tend to focus only on glucose in our OPD, while actually managing glucose is really tough. Managing weight and waste is even tougher. But it is quite easy to manage blood pressure and lipids. So when you're speaking with your patient, you give equal weight to all these four numbers. Madam, we will control your blood pressure, your weight, your cholesterol, and your glucose. All these four numbers put together influence our health later on. This is called metabolic karma. They influence our health and happiness as well. So we will try to get all these four numbers down. If not four, at least three will come down. So this is one point I would like to focus on. When you do not trivialize or high triglycerides. Secondly, when you are managing a patient with high glucose, try to find a reason. The reason will be any of the following. I for infection. I for irritation, that is psychosocial stress. I for inflammation. Like frozen, maybe patient has been taking corticosteroids or alternative medication. So these are some common reasons that we have to look for. And once we find the reason only, then we'll be able to fix it. On the other hand, at the end of the spectrum, if you have a patient who was doing very well and now suddenly glucose levels begin to fall, we have to find a reason. 3 medical reasons: renal, hepatic, gastrointestinal impairment. 3 endocrine reasons: pituitary, thyroid, adrenal failure. The commonest in my practice would be renal, followed by gastrointestinal, and also thyroid. Hypothyroidism is quite common. Another error that happens quite often is lack of focus on footwear. So do find a minute or so to tell your patient to buy good footwear and to make sure that there is no pressure point on the foot. And all this is done with teamwork. If everything cannot be done by you, because we are all busy doctors, train even your receptionist. Your receptionist just has to tell the patient, buy good footwear. If you're a person living with diabetes, buy your footwear in the evening. because at that time the feet are slightly swollen and you will get a better fit. If you buy footwear early morning, it is possible it might be too tight for you. So we are focusing today on errors in diabetes screening, diagnosis, non-drug therapy, drug therapy, monitoring, complication screening, and complication care. Let me end with 2 slides, and here we'll talk about communication and reaching out to the community. A good doctor cares. When we were all young, we had this picture of a very paternalistic, a very friendly doctor who cared for us. And there was no issue about fighting doctors, no hatred for the medical fraternity. The world we are living now is not very friendly. But if you actually care for your patients will care for you. So be confident, be competent, keep on upgrading your skills. Be accessible authentically. If you cannot attend phones at night, tell them upfront, I cannot attend phones at night. But 9 a.m. to 9 p.m. I'm here with you, or 9 a.m. to 5 p.m. I'm with you. Or if your phone comes later, my staff will attend. She will help you. Reciprocal respect. Respect your patient, respect the community that you work in. You will get that respect back. Be empathic to your community, to your patient, to the family, but express the empathy. Don't keep it in your heart only. Speak out. So you say, sir, I understand what you're going through. Young man, I know how difficult it is for you, but I'm here with you. Let's give it a shot. And be simple. Don't complicate things. Just be simple and be straightforward, and you will find that the world around you will also be equally simple and easy to live in. This was the competencies of a doctor, what attributes a good doctor should have. And I'm sure we all try to achieve this CARES framework. But when we communicate with our patient and with the family who is accompanying him, remember this water, W-A-T-E-R. If you want to water the plant of your practice, your private practice, then you had better water it well. And if you water it well, it will grow tall and strong. It will grow branches and leaves, which will create a very good canopy, a very good protection for us as we grow in our career. So whenever a patient comes to you, now tomorrow morning we'll do this. First of all, welcome warmly. Namaskar Didi. Namaskar Dada. How are you? How can I help you? Ask and assess. How can I help you? Listen to what the patient has to say. Assess. And then you tell the truth. You say, yes, madam, I have understood what you're saying. I think I am in a position to help you. Or I'm sure I can help you. All we need is just 10 days of medication. Explain with empathy. Sir, I'm starting this injection because of such and such reason. I'm increasing or decreasing your tablets because of such reason. I am prescribing a blood urea and serum creatinine because of this reason. I understand you had not come prepared to get these blood tests done today, but they're important. If not today, maybe we can do them tomorrow or next week. And reassure in return. Madam, I'm always with you. We'll do our best. If required, we'll take the help of a tertiary healthcare center. But till then, I'm with you. And do come back next week or next month or next quarter, whatever is genuine. And this same communication style is limited not only to our interaction with the patient. It should resonate in our communication with our community as well. So when you're speaking to the patient, you make your patient your ambassador. You make your patient an evangelist of your practice. How do you do that? So you say, let us say you have this lady who keeps on talking and shouting in your OPD. She keeps on asking a lot of questions. You get irritated with her. But the point is she is talkative. So don't get irritated. You utilize her skills. She knows how to talk. So you say, madam, when you go to the temple, when you go to the Gurdwara Sahib, when you go to church, do remember to tell everybody what I told you. Structured physical activity, sensible sustenance. Do remember to tell everybody about diet. Lord Krishna never said that he wants bundi ke laddu or he wants mithai or barfi. In the Mahabharata, in the Bhagavad Gita, what did God say that he wants? He says, anybody who gives me flower or leaf or fruit or water, I will be happy with that devotee. So you can drink as much water as you want, or even buttermilk. You can take as much flour, FLOWER, or fruit or leaves, green leafy vegetables and low-calorie fruits, and you will be fine. So, madam, do remember to tell everybody. So when this lady goes and she tells everybody, she will tell everybody, you know, my doctor, Dr. Manu Sharma from New Delhi, that handsome doctor, that young doctor, he's the one who told me all this. So who's going to gain? Who's going to benefit? Obviously, Dr. Manu Sharma will gain. All the other lovely ladies from the temple will come to meet him. So that is the way of communicating with your community. We also communicate with each other. Many times it is one way, because I keep on speaking. I think I am also like that talkative lady in the temple. But we do have bi-directional communication. And the questions for last week that we asked were, 35-year-old patient comes to your clinic with the newly diagnosed diabetes and no C-peptide. Weight loss was there. So what is her type of diabetes? It is type 1. Age is not a contraindication for diagnosis of type 1 diabetes, and many of you answered rightly. The next question was, hyponatremia can occur because of, and the answer is all of the above. It can occur because of emesis, NG tube suctioning, and diarrhea. Our questions for this week are, individuals with diabetes are at higher risk of heart disease if they, just one of them, A, smoke, B, have high HDL, C, they take aspirin, and D, they take a high fiber diet. So which of these is a risk factor for heart disease? Smoking, high HDL, aspirin use, high fiber intake. Our second question, which electrolyte deficiency can cause weakness, fatigue, cramping, paresthesia, paralysis, nausea, vomiting, constipation, cardiac instability, and lethargy? Is it hypernatremia, hypercalcemia, hypocalcemia, or hypokalemia? One of these is the most correct option. Which electrolyte deficiency or which electrolyte imbalance causes weakness, fatigue, and cramping, paresthesia, nausea, vomiting, and cardiac instability? High sodium, high calcium, low calcium, and low potassium. One of these is right. So we've had a long discussion today. I just realized 37 minutes. I think we are all inspired now by Neeraj Chopra and also by our athletes who are doing very well at the Paralympics. So because of that, हम भी अब लंबा करना शुरू कर दिया हमने. That's fine. We have lots of questions. To Tapan Kalita ji, hi. Good day to Dr. Ajay Pal Singh and Subhash Kashle. We have one question which comes from Dr. Sunandan Pratihar. How do I approach a post-COVID patient with fasting of 720, PP of 780, and generalized weakness? No other symptoms. At such high glucose levels, it should be insulin, sir. Immediate insulin. And do remember to get a urine ketone done. If the glucose levels are so high, certainly there is an acute pathology there. So you already mentioned COVID, it might be COVID, but do look for other things as well. Patient might be having tuberculosis or an abdominal infection. So search for that. The fact that there are no other symptoms like shortness of breath means respiratory compromise is not there. So look for genital infection, urinary infection, skin and soft tissue infection. But insulin should be started. Patient will feel afraid. So you tell the patient, insulin is just for a short period of time. It is to get you out of this post-COVID state. Once you have normalized, we'll bring you back to tablets. Another question from Dr. Jitendra Kumar Shah. When do we consider 50-50 premix instead of 30-70? That's a good question, sir. This is in patients who take a 2-meal pattern, heavy breakfast and heavy dinner. So first is meal pattern. Second is meal composition. The breakfast is very high in carbohydrates. Then again, 50-50 premix will be better. So meal pattern, meal composition. Third is meal quantity. So meal quantity, patient takes 10 idlis or patient takes 4 paranthas in the morning and he says, I just cannot do without it because I won't be able to work. And he says, I am willing to do anything else, but I will not change this. Then again, 50-50 premix. So sir, 3 things from diet: meal pattern, meal composition, meal quantity. Second, we go to glucophenotype or glucose profile. When the postprandial excursion is very high, postprandial minus fasting is more than 74, then 50-50 premix should be considered. How do we take 74? 200 minus 126. These are the diagnostic cutoffs for diabetes. So if 200 minus 126, that's 74. If the excursion is more than that, then 50-50 premix will be a good idea. You can also use 50-50 in the morning and 30-70 at night. Some patients where we do this would be in patients who follow a Jain lifestyle. So they will have a heavy breakfast and then their dinner will occur very early before dusk. This is where we use this hetero mix regimen, hetero mix, 50-50 in the morning, 30-70 at night. There is also something known as reverse hetero mix. Reverse hetero mix is used in the holy month of Ramadan. I will use 30-70 in the morning because patient is going to fast for a long period of time. But at iftar, iftar is the breaking of the fast in the evening after dusk. At that time, I will use a 50-50 because the calorie intake is quite high. Dr. Kishore Jumani says, as the cost of DAPA has come down, that is true, sir, you're right. Can we replace EMPA or CANA with DAPA? And how do you define? Sir, that is a very good question. If my patient has established ASCVD, patient has had a myocardial infarction in the past, I will continue to prefer EMPA. If, however, the patient is at high risk of CVD, the patient did not have an MI, is just at high risk of having MI, has unstable angina or other risk factors, then I can choose anything between DAPA and EMPA. EMPA, you can also use 25 milligram half tablet a day. So many doctors and patients do that. That way you're able to reduce the cost to half. Another very good question from Dr. Kishore, and that is that if metformin is not tolerated for pre-diabetes, what are the drugs? The drug of choice, sir, would be acarbose, 25 milligram BD or TDS with the heaviest meals. Usually BD will also suffice. Acarbose has been studied in many studies, including the Chinese diabetes prevention study, where it had something like 88% risk reduction in progression of diabetes. It has also been studied in the STOP NIDM trial, which showed that it had CV benefit, not only CV safety, but CV benefit in pre-diabetes. So acarbose would be my first choice. But if the patient is overweight or obese and patient has high risk of ASCVD, then maybe a GLP-1 RA like liraglutide would be first drug of choice. But that is injectable, slightly expensive. You have to talk to the patient. If patient is worried about weight, patient will take it. Let us look at some indications for pharmacological management of pre-diabetes. If your patient is symptomatic, if patient has got severe pre-diabetes, that means fasting is more than 110 or PP is more than 170, 180. If patient has got a wide spectrum, S for spectrum, of risk factors or other metabolic diseases, then again we will treat. If patient has got an acute sickness, S for sickness, like maybe a foot infection or TB, and you want to bring down the glucose so that the infection can resolve faster, then again we can use. Another S would be special situations like pregnancy, because GDM actually corresponds with pre-diabetes in terms of diagnostic criteria. Yet another S would be surgery. Patient wants to go for surgery and wants minimum glucose control. The other last S would be self-suggestion or self-need. That is, the patient himself says, sir, I want to keep my glucose perfect because I have a family history of diabetes. So tell me what to take. Then again, first choice is metformin, but you can use the others. This question from Dr. Posanlal Bisen is very important. On prescribing drugs, most people check it on Google and they ask a lot of questions. How can we deal with such Google gurus? So, Dr. Sahab, jo sachi baat hai, I myself get irritated. But do not let that irritation come on your face. My answer to such a patient will be, young man, you've done a great job. I really appreciate how much concerned you are about your health or about your mother's health. So well done, shabash. That is the beginning. Then the second is, but many of the websites, they give wrong information. So why don't you go to such a website and you give the website of maybe Endocrine Society of USA or RSSDI or Endocrine Society of India, and you say this is the guideline. Now that will be quite complicated. Patient will usually not want to read that. But your beginning should be you appreciate, you support, and then you deflect the patient. Or another way would be, I understand and I appreciate you've done a great job, but all these guidelines, how they are like, they're just like the manual that you get when you buy a new car. Now, whenever you bought your last car, you must remember there was this driving manual. Have you ever understood how to drive by using a driving manual? The answer is no. If you know how to drive, then you can read that driving manual and you can make sense of it, not the other way around. So that is what you tell the patient, but you tell it in a very soft and positive manner. One question is from Dr. Jitendra Kumar. Sir, if your patient has tuberculosis and patient is well controlled, patient is eating well, patient is maintaining weight, then OADs are good. Metformin would be drug of choice, and you can add a gliptin or whatever you want. But if patient is not well controlled, patient's tuberculosis is not improving, or patient's appetite is not good, patient is in a catabolic state, cachexic state, then we should shift to insulin for a short period of time. Many times you will see that patient is having good glucose because patient is not eating anything at all. There's no appetite. In such patients, actually insulin will be an anabolic effect. Dr. Rajeshwari speaks from my heart. Dr. Rajeshwari, I thought you were speaking from my OPD. So what she's telling me that both Dr. Rajeshwari and I, we feel that our medical nutrition therapy and exercise therapy is not up to the mark because it's a busy OPD. And we are always focusing on glucose numbers and drugs and insulin. That's true. How do we convince? Just little bit, little at a time, little at a time. If you allow over the next few weeks, whatever the topic is, I will add something like diet made simple in 3 minutes and exercise made simple in 3 minutes. And we will discuss this in the next couple of weeks. Pallavi Rai ji has a question. Please help with the case. 81-year female with history of diabetes for 25 years. Okay. On glargine once a day, glycid MR once a day, linagliptin once a day. Fasting glucose is 170 to 180. In such, EGFR is 40 only. Okay. You have not shared the postprandial glucose, but I assume that it won't be very high. A nice way would be to stop the glargine and glycid MR and shift the patient to premixed analog. So premixed analog, let me use the trade names: Rhizodeg, Humalog 2575, Eglucent 2575, and Novomix. If cost is not an issue, Rhizodeg would be our first choice because risk of hypo is minimal. The dose for this lady would be something like 15 units twice a day. That is total of 30 units. So we will stop glargine 26, stop glycid MR, and shift to Rhizodeg or Novomix or Eglucent 2575 or Humalog 2575, 15 units twice a day. I'm sure the glucose will come down within a week or so. For Dr. Palvi Rai's question, when you counsel your patient, tell her that first you will feel good. You will get an anabolic effect. After that, your postprandial glucose will come down, and fasting glucose will take about 10-12 days to come down because we don't want to be very fast. This way, you will be able to preempt your patient from arguing with you when she comes next week for follow-up. We have another question, just one more question let me take. This is from Vivek Tiwari sir. Fasting glucose of 134, random of 206, okay. Post-COVID after 3 months, CT scan is still showing 7/25. If that is the case, it means there is some issue with the respiratory function. So we have to actually get a respiratory evaluation done, and the glucose values should be managed. So maybe metformin 500 BD along with vildagliptin or linagliptin, and do get an HbA1c, sir. We must get an HbA1c done. If that is not available, then my first line would be linagliptin plus metformin, even at an ESR of with an ESR of 45. CRP is 4.8, which is nice, but the CT scan then does not correspond with that, sir. So maybe the CT scan should be done again, or we should take a pulmonologist's opinion. It might be something else like an interstitial lung disease. We've had lots of questions today, and we've had a very long discussion. But I'd like to thank you all for this interactive session today. We keep on speaking with each other, we keep on learning from each other, and we keep on trying to improve our quality of care. We keep on trying to minimize our errors. That is what we have to do as doctors, and that is what we are all doing. And I'm very happy that we are part of this journey together. We are one family trying to fight, trying to do our best for a happy and a healthy India. Thank you, and Jai Hind.
So I think you have already taken a long time today, 50. I won't take any minute more. I thank you, and I would suggest that only looking into the questions that maybe 2-3 weeks before we have discussed that we need to program our diabetes essential in a way that we take up cases like we have discussed and we left And just to reassure our doctors viewers that we are working on it, and Dr. Kalra will soon, he's not going to end up with 52 weeks. I have already told him, and he's already agreed with him, because with the number of doctors coming and asking questions, that gives me enough confidence that we need to take it more longer, and we need to get more case based studies, and we are working on it, on the concept. Thank you very much, sir, and Jai Hind. Good night.